Hello, this is Patrick Grabbe, 10/28/2020. This is my Unit 4 case studies video. I chose Case 2 and Case 3. So Case 2. A 4-day-old infant with normal birth weight delivered vaginally is found to have an elevated phenylalanine, 6.6, from her newborn screening. With a presumptive diagnosis of phenylketonuria, more samples have been sent for analysis. The parents deny any family history of PKU. The consequence of this presentation is that tyrosine may become an essential amino acid. Phenylalanine is converted to tyrosine by phenylalanine hydrolase with BH4 as a cofactor. With the body unable to generate tyrosine, it now becomes an essential amino acid and must be obtained in the diet. Phenylketonuria can be caused by deficiency in phenylalanine hydrolase or tetrahydropterin BH4. Deficiency in BH4 can be classified into 4 forms. The first two are guanosine triphosphate cyclohydrolase 1 and 6-pyruvoyl tetrahydropterin synthase deficiencies. These are from defects in tetrahydropterin creation. The next two, p-terin 4-alpha carbinolamine dehydratase deficiency and dihydropterin reductase deficiency, are defects in BH4 regeneration. Both conditions, BH4 deficiency and PAH deficiency, are genetic autosomal disorders. The conversion of phenylalanine to tyrosine to fumarate provides a TCA intermediate for the production of ATP, as well as neurotransmitter production of dopamine, norepinephrine, and epinephrine, makes the diagnosis of these deficiencies of vital importance to proving patient outcomes. Tests for these are generally done in newborn screenings. Diagnosing these early is very important for the outcome of the patient. Dietary changes and oral medications can improve the patient's life. When comparing the BH4 loading tests of patient A and patient B, one can interpret that patient B has a BH4 deficiency and that patient A has a PAH deficiency. Patient B's phenylalanine levels drop significantly over the 8-hour period of the test. This is indicative of a BH4 deficiency. Patient A's phenylalanine level was slightly elevated for the BH4 loading test at both 4 and 8 hours. This result would indicate that the patient has normal levels of BH4 and possibly has a PAH deficiency. But we must be careful, as data suggests only about 2/3 of the patients suffering from a BH4 deficiency are receptive to the BH4 cofactor loading test. This means about 33% of those tested do not respond and will need further testing to determine why they didn't respond. Patient A will need further testing to determine the exact cause of PKU. Case 3. A 47-year-old male presenting with the classical symptoms of gout, pain in his right toe, unable to bear weight, and no apparent trauma. Labs, the patient plasma urate is elevated at 10.5 milligrams per 100 milliliters, and the urinary uric acid is markedly decreased at 215 milligrams over 24 hours. So gout is typically caused by one of 3 problems: underexcretion of uric acid in the kidneys, increased uric acid production due to purine overproduction, or decreased purine salvage. The best explanation for the presentation of gout with this patient's symptoms in labs is a decreased urinary excretion of uric acid. The kidneys normally retain about 90% of the uric acid that is filtered through. His plasma urate is elevated, but that's most likely from reduced elimination from the kidneys. Both purine overproduction and decreased salvage of purines are from genetic mutations that would have been discovered when our patient was much younger. Leishman disease is a purine overproduction issue related to the absence of hypoxanthine guanine phosphoribosyl transferase activity or failure to reutilize hypoxanthine. Von Gurk disease is a glycogen storage disease. This causes either a deficiency or gene mutation in glucose 6-phosphatase or glucose 6-phosphate translocase. The high levels of lactic acid caused by this compete for excretion with uric acid. This causes the patient to suffer from gout. The patient's recent dietary change from diet soda to regular soda is most likely the cause of his elevated uric acid levels. The 4 to 5 liters, he states, is a large amount of fructose. Fructose metabolism bypasses PFK1 and is less regulated than glycolysis. When there is a high intake of fructose, phosphorylation into fructose 1-phosphate is fast, but the reaction with aldolase is slow. Hence, fructose 1-phosphate accumulates and the intracellular phosphate decreases. This decrease stimulates AMP deaminase, which catalyzes the degradation of AMP to inosine monophosphate, increasing the rate of purine degradation. The purine degradation produces uric acid and generates mitochondrial oxidants. Fructose also stimulates uric acid synthesis from amino acid precursors such as glycine. Long-term fructose ingestion suppresses renal excretion of uric acid, resulting in elevated serum uric acid levels. The patient should be educated on the challenges with ingesting large amounts of fructose. Currently, research shows both positive and negative benefits to retaining uric acid. Thank you.